why would you want to take out your own stem cells that are aged and older and just put them back into your body?
Right, exactly. And, a lot of people coming to us for stem cells, they're doing it because they don't feel good. For me, the umbilical cells have been a game changer because number one, it doesn't involve the procedure. So practically that's a lot easier for patients. But number two, these are brand new power-packed stem cells that are coming from the mesenchymal cells of umbilical cords, okay? These stem cells are not regenerative. These are just honing in to where they're needed in the body, releasing exosomes, and causing your own natural stem cells to just function better and create a healing cascade.
Darshan, one of the things I know at last night's supper club you were talking about, and let's just dive straight into it. We were discussing stem cells last night, and you were talking about adipose tissue stem cells and why you think they're not that effective. So can we tell the audience a little bit about your hot take on stem cells, exosomes, and adipose tissue stem cells?
Yeah, so, I think the way I have a view of this is coming from just a very practical lens, right?
Mm-hmm.
And so we have over a dozen clinics now. We'll have 30 by the end of this year at Next Health. And we do stem cells for people. And when people are faced with many choices and many conceptions on stem cells, they get really confused because it is a really confusing market out there around stem cells. And the reality is things are being done a certain way for a long time because of regulatory concerns and because the science just kind of stood still because the FDA basically, took the legs out from under the scientific research with their declaration that stem cells are not FDA approved, et cetera, and other things that they put into place. And what I could tell you is that adipose-derived stem cells are probably the first methodology that people use for stem cells therapies, okay? And so to talk about adipose-derived stem cells right now, you're still talking about the same technology that they've been using probably since the 80s,
Wow, it's that long and it hasn't been adjusted.
Well, yeah, I mean, there's not a lot of difference about adipose-derived stem cells. So let's talk about stem cells just in general. Stem cells are derived either from your own body or they come from, right now, umbilical cords, right? From donated umbilical cords from babies that have already been born. These are not embryonic. Just want to be very clear. Embryonic stem cells are not utilized anywhere pretty much because of ethical concerns about where you get them from.
Right.
And when I say that, that's like the public-facing view of what we can say. I do know there are people using embryonic stem cells, and I don't even want to talk about it because I just feel like it's such a charged topic, and we don't use them, and I wouldn't use them.
Right.
Okay, so moving past that, when you get stem cells from your own body, either from your fat or from your bone marrow, okay, and you can even get some from your blood as well. If you have a plasma exchange machine, you can separate them out. It involves doing a procedure on you. So to get fat-derived stem cells, we have to do a little mini liposuction procedure. To get bone marrow stem cells, we have to put like a device in your hip, and then we can get them out, and then we can separate them, and we can then use them on your own body. But in the United States, what you cannot do is what's called manipulating the stem cells. That means you can't grow them in a petri dish to make one stem cell into millions of stem cells, okay? And you can't do anything else with them. You just only remove them and re-inject them, okay? It involves more of a recovery for you as a patient because you have to take them out from your own body. I mean, this is not like, these stem cells are your same old stem cells that have already been dividing in your body for a long time.
That's what I was going to ask you.
Right? That have been exposed to the environmental toxins, the DNA damage, all of this happens over time. So it's your same old stem cells, okay? And not you, Iman. Like, you look great.
But most average people, we've been battered and bruised so much from environmental toxins, heavy metals. This life happens. And I'm like, why would you want to take out your own stem cells that are aged and older and just put them back into your body?
Right, exactly. And, a lot of people coming to us for stem cells, they're doing it because they don't feel good. And so their stem cells are not right now working very well for them. For me, the umbilical cells have been a game changer because number one, it doesn't involve the procedure. So practically that's a lot easier for patients. But number two, these are brand new power-packed stem cells that are coming from the mesenchymal cells of umbilical cords, okay? Okay, here's a second biggest misconception that people have about stem cells that no one really talks about. These stem cells are not regenerative, okay? These are just honing in to where they're needed in the body, and they're inducing a healing cascade through releasing exosomes and causing your own natural stem cells to just function better and create a healing cascade, okay? And so when you're using stem cells for that purpose, okay, whether they be mesenchymal cells from umbilical cords, hematopoietic, or fat-derived stem cells, you want to get the most bang for your buck when you're putting them in, right?
Right.
And so these adipose-derived stem cells, they're your same old stem cells. They don't have a lot of exosomes in them, which are basically the power.
Yeah.
They don't have a lot of
Powerhouse.
mitochondria in them, because mitochondria also transfer from stem cells into your current stem cells. And so they really don't pack a power punch, to be honest with you, you know? And so I think that's where people get really confused about the use of stem cell therapy. And a lot of the literature shows, especially the orthopedic literature shows, that if you just take someone's plasma, PRP, and use that, it's probably just as effective, if not even more, than actually using adipose-derived stem cells, right? And so you got to be really careful about, you know, what you're buying, because right now it's the Wild West of the United States. The marketing is all over the place. People are promising all sorts of crazy things. You know, I do think, like, for cosmetic purposes, stem cells work great. Like, if you do a little mini lipo, then you inject into your face, you get some fat in your face, and then the adipose can also cause the tissues to heal, fibroblasts and collagen. That all works really well for that one purpose. But for general wellness and healing, I'm not a huge fan of using adipose-derived stem cells. Sorry, that was a really long answer to your question.
No, but it's really great, because I think it gives the audience the insight into what works, what doesn't, from your medical lens and what you're actually seeing. So at Next Health, you guys have like 30 clinics pretty much, right? So you're seeing so much patient data come in at all times. So when you guys are giving patients stem cell protocols, right? Who is a candidate? Why are they a candidate? What markers and stuff are coming out for them? And then what dosage are you deploying to them?
Yeah, and so, you know, here's the thing, like, the way you have to think about every patient is very N of one on this, right? And so pretty much as far as candidacy is concerned, we really stick to people that are using stem cells in either a healthy environment, like they are pretty healthy, but they just want to accelerate their longevity journey, or we use them for people that are actually like having pain, you know, like a joint musculoskeletal pain. And they always, you know, they've already seen an orthopod, they've already seen physical therapy. They're kind of like just trying what else is out there. And in those cases, we can help them relieve their pain as well, and inflammation as well. And so it's really just, you know, going through all the risks and benefits, and be very clear with patients. These are not FDA approved. Okay. The FDA will not approve stem cells for any type of disease indication. And then, you know, now the laws are changing. The right to try laws are called in a few states like Florida. I think Wyoming is one of them, either Wyoming or Montana, Utah. And so I think it's a little bit different in those states right now with how you can talk about stem cells. But, you know, I think those are kind of like the main indications that we see. And we're pretty much sticking to mesenchymal cells from cords. And so that's kind of where we're at right now. I think the science, though, because, you know, in Japan, where a lot of these scientists have won prizes and Nobel prizes for their research, they've really been enabled by Japan modifying their regulatory bodies and their environment to where they can really accelerate the stem cell research and regenerative research outside of a drug research environment, right? And so, unfortunately, in the United States, because we have these massive pharmaceutical companies that really influence how things are put out there, stem cell therapy has really been, I think the science of stem cell therapy is not advanced because we only have the FDA, right? And the FDA has a lot of influence on it by the pharmaceutical companies that fund it, right? And it's unfortunately, you know, it's not in the best interest of the pharmaceutical companies for there to be like this stem cell therapy that can, you know, get you off your pharmaceuticals, right? Absolutely. Because then they lose their incentive to create pharmaceuticals. And so, you know, I'm not a conspiracy theorist or anything, but this is just the reality of money and how money flows in the world. And this is the reality of where we're at right now. So there is one new cell that I'm really excited about. It's called a Muse cell, MUSC cell, developed in Japan. And these are actually...
And this is separate to the NK cells, right?
Yes, these are separate. And Muse cells, they're saying they're actually regenerative, right?
Okay.
And so I'm diving into the science around Muse cells right now because I think this could be a game changer, because people don't want to have surgery anymore. They don't have knee replacements and hip replacements and shoulder replacements. And, and what about people that are suffering from neurodegenerative diseases?
MS.
There's no, MS, there's no treatment actually to reverse the course of these diseases. So super excited about Muse cells, Yamanaka treatments, and what's going on there is incredibly exciting. And I think in the next 10 years, we're really going to see a quantum leap in regenerative medicine. Sadly, it's not going to come from a United States-based company unless they figure out a way
to allow the research to get
politically make this happen. Yeah.
When it comes to the Muse cells, Darshan, where are people deriving them from? What is the conditions they're harvested in? Is there a little bit more information on that?
Yeah, I mean, they're doing most of this all in Japan, as far as I know. And so I have yet to visit their labs. I'm really trying to get out there to visit them. And also my kids really want to go to Japan. So I'm going to try to
family trip right there.
Yeah, and I want to really spend some time with the scientists that are doing this. Yeah, it's really interesting. I don't have a lot of specific details there from you, but for you, I do know they come from the umbilical cords as well. So they're harvested from cords. And I do know that they are put through a very specific extraction technique. And so that's all I know at this moment.
And when you're doing the mesenchyme stem cells for patients right now, is there a specific dosage you always stick to within certain parameters that you don't go above?
No, it's very much dependent on the severity of whatever the patient is going after. There's a cost to every 5 million stem cells, there's a cost to it. So how much it's actually going to be within the means of the patient to do. And then also we always tell people, you don't have to do 100 million stem cells to start off with. These are really powerful mesenchymal cells. So let's start with a lower dose, see if you have any improvement and how long that improvement lasts. And if it lasts like a good amount of time, you don't need to increase the dose. We already know this dose worked for you for 6 months. Let's just stick with that, so.
And then are you also stacking during these treatments things like exosomes in there as well? Do you see incredible results stacking stem cells with exosome treatments spaced out a little bit?
Absolutely. Okay, so stem cells will work much, much better if you give them the right environment in which to succeed, okay? So that involves, number one, reducing inflammation as much as possible. Prior to the stem cell therapy. And so we are actually using plasma exchange to reduce kind of the inflammatory milieu of the body and reduce a toxic burden of the body prior to stem cell therapy. Then stem cells in just healing in general need a positive healing environment. That means giving it all the precursors it needs to create that, including NAD. So we use IV NAD, IV nutrients, and also hyperbaric oxygen therapy has been shown to accelerate the efficacy of stem cell therapy as well. So we're doing all of this in combination anytime someone gets stem cells.
And when it comes to TPE, can we talk through the difference between also something like a TPE and apheresis? Because those are both such hot things that you see all over social media. I think Paul Saladino recently did it as well. And so you see people posting about it with their big bags. So can we walk the listeners through the treatment for both, what your take is on both of them, and essentially what are some of the results people can expect besides lowering inflammation, and what is the duration the treatment actually lasts?
Yes. Okay. So let's talk through just like stem cells, we're going to divide it up in two big categories. Okay. So for those listeners who don't really know what we're talking about here, these are advanced therapies that some clinics are doing, like in Next Health, we do these therapies. And basically we sit you down in a chair like this one, we hook you up with 2 IVs, we remove your blood from one arm, put it through some sort of process, and we put it back in the other arm, right? So we're creating a circuit with a machine, okay? And that circuit involves a machine that does something. So what does plasma exchange do? Plasma exchange, that machine is basically a giant centrifuge. So if you've ever had PRP done, they take your blood, they put it in a centrifuge, and they separate it into your plasma and your blood cells. And so the plasma exchange machine does the same thing, but for your entire blood volume. And then we put in your blood cells back, because obviously you need your blood cells to carry oxygen. And then we replace the plasma that's been removed, which is a liquid portion of your blood, with albumin and IV fluid, okay? And so what that does is basically removes that portion of your blood, the liquid portion of your blood that is not your red cells, completely. Inside, what lives in your plasma? everything that we're testing for using a blood test, right? Inflammatory cytokine, toxin levels, heavy metals,
herbicides, pesticides.
Yeah, immune complexes, right?
Spike proteins.
Spike proteins, all of that lives in your plasma. And so when you remove it, so that's the pictures you see of people opening up 3 bags of plasma, everything's in there and you basically throw it out and you're replacing it with fresh new fluid with nothing in it.
Okay.
And what that means is basically like an oil change for your body. You're getting rid of the old, putting in new, and it's an oil change for your body. There's one critical factor to this that a lot of people don't know about, which is albumin. So your body has this protein in it called albumin. It's a large protein that's very sticky. And this protein goes through your body, mopping up toxins and cytokines and damaged proteins. And then it transports those to your liver and your kidney for elimination. When you're at a state where you have a high toxic burden or a high inflammatory burden, that albumin is all bound up. It doesn't have any more room on it. Think of it as like janitors or buckets, and the buckets are all full.
Right.
So when we do therapeutic plasma exchange, we remove all the old janitor buckets and we put in brand new buckets. So now you have a fresh new set of albumin in your blood that can go around mopping up all of these toxins and inflammatory mediators, damaged proteins that are in your organs everywhere in your body. So you also get that as an added benefit. So I love plasma exchange. I do it every quarter. I think it's a really good reset for your body. It's a really good way to induce an environment in your body where if you were to do stem cells, they can just work a lot better.
Yeah, because the inflammation is so much lower in your body. It's cleaner. The receptors are cleaner to receive it.
Exactly.
And what is the core difference, Darshan, between TPE, which is therapeutic plasma exchange, and inapheresis?
Yeah, so there's inapheresis and there's other. So inapheresis is like a filter. So instead of removing the plasma, you're putting it through a filter and then you're re-injecting it into your body. And these filters do specific things. So like inapheresis removes spike protein, they say, right? There's another filter called Clarity or something that removes, they say, plastics maybe, okay? To be very clear, you're just getting specific things removed from your plasma, but everything else is still filtering through. What does that mean? It means you're getting your old albumin back. You're getting your old plasma back with specific items that this filter has removed. So I think these filters are great if you're going after something specific. It's not a full oil change though. It's your same oil, just removing some compound within it. Right. And then you're getting it back, right? And so that's basically the difference between filters and plasma exchange. So why would you do that, right? So why would you do that? Well, number one, albumin is hard to source and it's expensive. And so to get new albumin, we can source it really easily in the United States, but it's very difficult to source in other countries. Most of the albumin in the world is made in the United States and is shipped
locally.
Out. Yeah. We have a huge, very robust albumin industry in the United States, but not in other countries. Many of them are importing it from the United States. And so number one, that's one reason that you would do it. Number two is that I think some people just want to go after something specific. They don't want to remove everything, you know? Right. And so, you know, I think there's going to be a role for many of these filters and also plasma exchange in all sorts of different patients. And once again, it's very N of one. The only thing that concerns me about some of these filters is there's not a lot of robust research around it. And so we don't really know like exactly how it's working for the population. But what we can do is N of one research, meaning we can measure on you, for example, say you're trying to remove spike protein, right? There's tests that you can get for spike protein. You can measure before and after, and you can then see, like, did this filter work for you? And if it did, amazing, perfect. You just keep going with it, right? What I love about plasma exchange is there's good research of how it works. There's a great study on Alzheimer's disease, for example.
Wow.
And, you know, with Alzheimer's, you have all these like malformed proteins that are residing in your bloodstream, and it's multifactorial as well. So you have like inflammation, toxic exposure, all of this adds up to why people's Alzheimer's keeps progressing, right? And so with plasma exchanges, there's a double-blind, placebo-controlled, randomized study using plasma exchange to slow the progression of Alzheimer's, called the AMBAR study, where it works better than any medicine out there for Alzheimer's.
Insane.
Exactly. It's insane. It's like, why doesn't
more people have access to them, started at a younger age? So if you test, genetic testing is so important nowadays. And if you are a candidate and you're feeling signs and symptoms come up for you, why not go down this route earlier?
I think that's the way the research is moving, and so plasma exchange as a therapy has been around since 1970s when it was FDA approved.
Right.
We're not adding anything to your body. It's a FDA approved machine for literally 50 years plus.
Yeah.
And it's, obviously every procedure has its risks, but this is one of the safest procedures that you can do.
Yeah.
And so I'm a real fan of it.
Would anybody not be a candidate? Has anybody
Yeah.
walked in through your door who does not qualify to be a candidate?
Yeah. So there's, some people have very small, fragile veins. Okay.
I might be one of those people.
Yeah. And so for those people, we have to
Yeah.
be very careful
Right.
about where we put these IVs in.
Right.
And so for someone like with small fragile veins, we'll use what's called the midline IV,
Okay.
where we use an ultrasound to actually put an IV in the upper arm into the
Okay.
big vein that goes to
Because
your
it's a pretty
bicep
gauge.
muscle.
It's a pretty a 16 or 18 gauge.
It's an 18 gauge
Yeah.
needle that we use. It's a big gauge needle, and it's using pumps. So it's like it's a lot of pressure on your vein, and so if you have small fragile veins, it can be more difficult, right?
Right.
So I think, that's one thing you have to take a look at. Number two, a lot of people have like very vasovagal and they get really, I would say, they feel sick and they get faint when at this mere sight of an IV. And so those people we have to be very careful with as well.
What do you do with them, by the way? Do you have to gas them? Do you have to give them a little Xanax, a
We don't-
Valium?
no,
What
we
do you
don't-
do?
We don't do any of that. We just kind of coach them through it. And some people just can't do it.
Yeah.
These are the people that come in just for an IV and they just like immediately faint. And you're like, okay, you just probably should avoid this kind of stuff,
There's no way to just give them a little bit of a Xanax or a Valium to just calm them?
You can, but remember that
It affects.
It affects the procedure. And also the minute you start the procedure, you're going to remove that from the bloodstream. You're going to remove even that drug.
Yeah.
So like whenever someone's getting plasma exchange, we tell them like, whatever drugs you take, like your high blood pressure medication, your Crestor, Rosuvastatin, like you're going to have a blood level, plasma level almost zero. So it will be ineffective for today. By the way, this is another really good reason to use plasma exchange is that for people with really high cholesterol or with LP little a,
Right.
It's very effective. And in fact, the American Heart Association has recommended plasma exchange as a therapeutic intervention for people with high LP little a. Okay. And also familial hypercholesterolemia is like a mainstay of that treatment protocol as well.
Wow.
So,
And people are not talking about this enough. It's such a great, treatment to do. And so many, I think a lot of guys aged between like 35 onwards now get diagnosed with high cholesterol, high blood pressure, and they're not directed to these treatments immediately, but instead they're directed to take a pharmaceutical grade pill.
Yeah, but that's because these treatments can be expensive. And so they're not for everyone because it's just not affordable, And so the second thing is that I keep saying it's very N of one. Like it can work for you or it cannot work for you. So you always need like a pharmaceutical backup to keep you, option and also to keep you stabilized day to day. Because the last thing you want to do is not do a pharmaceutical and then your plaque progresses and then you become in trouble. You need a stent or you have a heart attack, God forbid, right? So I think, every patient, you just have to have a really skilled doctor taking care of that patient and is able to use all the tools available to them to create a protocol that works for you and that's going to be sustainable, right?
Yeah.
It's also
financially and emotionally and physically.
Yeah. Like, I don't know how many times a year I do plasma exchange. I try to do it every quarter, but obviously like I get busy and it gets skipped. And you like when you're dealing with high cholesterol, hypertension, autoimmune disease, you can't skip a treatment because then it just flares up, right? So
also looking at you have 30 practices all over. What are some of the most common medications that people walk in being on and that you guys from these longevity practices have been able to successfully take people off and get them healthier?
Yeah, it's a great question. So, we love reducing dose and then eventually even stopping pharmaceuticals if at all possible. And the way this whole process works is you come in, we work with your doctor who's prescribed those medications to say, hey, this is the plan. A lot of doctors now, believe it or not, are very excited. They're like, oh, wow, this is great. Yeah, let's work together. Let's see what we can do, right? And then the way we do this is we work hand in hand with them. So there's like this kind of like double check system. So they're reducing dose and then eventually taking someone off of it while we're working with them. So where has this worked with? Metabolic disease, very, very successful with kind of eliminating for many people, their high hemoglobin A1C, reversing diabetes,
Right.
reversing a metabolic disease in general. Secondly, we've had a lot of success in autoimmune disease. A lot of people on very expensive biologics that cost like $30,000 to $50,000 a year.
Wow.
And we can either space out the dosages more or even eliminate the need. Thirdly, I would say is for like cardiovascular disease. I think a lot of people are on high dose, like multimodal high dose therapy for having high cholesterol. And once you fix their metabolic disease and you reduce their
Cholesterol gets
inflammation
adjusted.
and their cholesterol just gets better and they don't need all that. So yeah, like all the chronic diseases basically.
Also, we don't realize how common elevated blood pressure is, especially in men again. And so, last time we were talking about this with Rhonda Patrick, having really elevated blood pressure can lead later down the line. It's now being linked to things like Alzheimer's and dementia. So why is that? Is it because there's a rise in chronic inflammation that people are getting more diagnosed with higher blood pressure? What do you think is correlating down to?
Yeah. So the reason why more people have high blood pressure is because blood pressure is a combination of multi-factors that tie into how your blood vessels in your body to every single organ are managing your blood pressure. And so high blood pressure is the end result of long periods of stress, long periods of sedentary activity, long periods of lack of sleep, and also metabolic disease can all lead to this kind of like, yin and yang of high blood pressure and metabolic disease as well. So all of those things lead to high blood pressure. And high blood pressure then leads to all forms of chronic disease. And if you look at the top 10 causes of death on the CDC, like number one is heart attacks, right?
Yeah.
Heart attacks happen just as frequently for men as for women. Men have like large vessel disease where they have big blockages in their blood vessel. Many women die of heart attacks because of small vessel disease that's due to high blood pressure. Okay.
Right.
High blood pressure also leads to Alzheimer's, as you mentioned, and many other neurological diseases. And that's because guess what? Your brain has blood vessels too. And if your brain has blood vessels that are not functioning properly because of hypertension, it does accelerate the risk of blood pressure causing Alzheimer's. Same thing for kidney disease, same thing for liver disease, even peripheral vascular disease. All of it is linked to high blood pressure. Yep.
And what are the kind of tests, Darshan, when people walk into a Next Health, are the first round of diagnostic testing you guys are running to even see what is somebody's baseline to then start working them up to other things?
Yeah, so that's a great question. Thank you for asking this because I think a lot of people think that it's just you do a blood test, it gives you everything you need.
Of course
and that's not
yeah.
true, right? So our baseline includes obviously a blood test. Okay, so this is getting biomarkers that are critical to your health to give us a look under the hood of what are you doing along all of the different factors that are going to affect your health. We talk about metabolic disease a lot, inflammation, your ability to detox, like your liver, kidney health, your cardiovascular risk factors. We're checking all of it, your toxin levels. But then beyond that, we want physical measures of how your body is doing as well. So that includes your VO2 max. That's a measure of your cardiovascular fitness.
And a lot of places are not checking that.
Yeah, we check that.
Yeah.
We check your grip strength. So we have this machine that you squeeze and it gives us your grip strength. And that's a measure of your overall strength. And, I would say half the people we do this on, they're so surprised that they're not as strong as they need to be.
Yeah.
Right, exactly.
For their age.
Grip strength drops off a cliff after 40 if you're not strength training.
Okay.
So it's very important. In fact, people listening to this can do this at home. Just go on Amazon, buy what's called a grip dynamometer. They're like $15 and you can measure this at home. Thirdly, we're measuring your balance and your mobility. So we do a balance mobility assessment.
Right.
Fourthly, we're doing a cognitive health screening as well. So we sit you down in front of a computer. Some of our locations, we actually have like this little cap we put on that we're measuring EEG signals and blood flow. But you don't even need that. You can do this in front of a computer on a test. And then what else are we measuring? Oh, and then we're measuring obviously blood pressure, but also we're measuring using a special device, how your small blood vessels are working as well.
Okay.
And then obviously we're doing, very important, everyone should do this too, is we're measuring your body composition.
I was going to say, so a DEXA scan or something.
We don't use a DEXA scan. We're actually using a bioimpedance scanner, but we send everyone, we highly recommend everyone get a DEXA scan once a year after the age of 40.
Okay. And what are you seeing a lot of times, because everybody's on this trend of GLP-1s and everyone's gone crazy with it. They're sometimes not medically supervised while doing GLP-1s. The protein intake is not that great anyways. How much is it affecting now bone density when you're running people through these diagnostics? Do you see a huge drop in people's bone density and like strength because they're doing a lot of these unregulated GLP-1s?
Yeah, I mean, look, at our clinics, our patients come to us to do the GLP-1.
Of course, but under medical supervision.
Under medical supervision, there's no reason to have bone loss. There's no reason to have muscle
Correct.
loss. There's no reason to have any of these issues. But when you're buying them online, or your GP that only has 10 minutes with you just writing your prescriptions,
Here you go,
like, here you go, take this. That's when people get into trouble, right? And so, yes, we are seeing a lot of people that have lost bone mass. And I'm a surgeon, so we used to do gastric bypass surgery, which is very similar to GLP-1s. If you look at like the progression of what happens to patients and people with gastric bypass surgery, a lot of the weight loss was muscle loss. A lot of the weight loss was bone loss, and they're severely nutrient deficient. And so that's what happens with GLP-1s. If you just like escalate the dose to the max dose without any supervision and without, doing all these things like getting your nutrients in order, high protein intake, strength training, sleeping better, getting your metabolic health fix, wearing a continuous glucose monitor. We do all of that when we put someone on GLP-1. So GLP-1s, I think, are one of the most transformative drugs that have come out in decades. And it's going to, I think, be a big part of turning around this like massive progression of chronic
obesity and chronic disease.
Obesity and chronic disease, right, exactly. But you have to do it right.
Under the right medical supervision with a practitioner who understands the nutrient density that you need to have, needs to do the right exercise, make sure you're eating correctly, all of those things combined, because it's a very powerful tool.
Anyone that's on a GLP-1 should really, read a book on how to use them correctly. So Ashley Koff wrote a book, and also Dr. Rocio Salas-Whalen wrote a book. They both wrote 2 incredible books that have come out this year on how to do GLP-1 successfully. And there's a lot of like psychological implications here as well. So you have to also think through that. And so, highly recommend you get educated before doing a GLP-1.
How are you feeling about the recent announcement that the FDA might put the 14, 15 peptides that had kind of taken off the market back on the market? And what's your hot take on peptides currently at the moment?
Great question. Okay, so peptides, just like, stem cells and a lot of these therapies, it's like the Wild West, right now.
Yeah.
And so people really need to understand the Wild West of this whole thing. So again, there's 2 categories, okay? So there's compounded peptides that you can get from compounding pharmacies, and then there's for research use only. And let me tell you what happens for the research use only peptides. A giant vat of powder is delivered from China to America. And they someone scoops it into a little glass vial and puts a label on it and says, here you go. That'll be, they take something that's created for $5 a vial and they sell it to you for $150 a vial.
You don't know if it's stable. It's not third-party tested. You don't know what you're injecting into your body. You don't even know if it's good or bad, if it's just water.
Right. Exactly. Or you don't even know what's in it. Yeah. That's what's scary. Okay. So obviously, I'm not a fan of using research for peptides, and you got to just be super careful there. Now, the other category, which is compounded peptides. Okay. So these are made in what's called compounding pharmacies. And those are
with tight regulations.
Yeah, with tighter regulations, but still there's some variability there, right? You have to make sure these are like individual shops that they're definitely functioning under what's called the 503 license, but you have to make sure that you're going to like a very reputable one. And so again, working with a practitioner that has some responsibility to you as the patient to choose the right pharmacy, to choose the right medication, the right dosage, I think is also very important.
Right.
And then you have like the ones that are made at pharmaceutical companies. So like pharma is making GLP-1s. Those are also peptides, right? And they're like under super tight regulations. So you can be pretty confident that if you're buying like Ozempic or Mounjaro, that you're getting like the right thing. The right thing. Right? Now, I will say like I've gotten tirzepatide even for myself from like a compounding pharmacy in the past that was making it and it didn't work. I'm like, what's going on here? And probably like if I had third party tested it, right, it would be a problem. Right. So buyer beware on peptides. I do think that now that RFK said on Joe Rogan that, he's looking at putting these 14 peptides back into a regulatory state, that's a big win because that means that compounding pharmacies can now make these and under tight controls. And the research grade stuff goes away. Right. Exactly. So I think it's a step in the right direction. the biggest problem with peptides is that there's just not robust studies around them.
And they're also not a miracle drug.
Right.
They're just not. I understand with GLP-1s, they're transformative completely to people's lives, but I feel that peptides are signaling molecules to your body. So they can only do in your body what the terrain is allowing them to doing. 100%. So there are other things that you at Next Health, for example, do, which is fix somebody's sleep, make sure their macronutrient density goes up. You're, doing an environmental toxin overload, taking all that stuff out. That prepares the terrain to receive these signaling molecules in a much better way.
Exactly. And so well said. You use peptides when you need them, but if the biology is not
ready
in a ready, good state, they're not going to be very effective, and then you're wasting your money and your time. So
and they're expensive, by the way.
Yeah.
Pharmaceutical grade peptides, a protocol for 2 months can run you anywhere from $35,000 to $7,000. It's not cheap. And I always tell people, work on your foundational health first. Do the diagnostic testing, understand your baseline, work on hydration, sleep, nutrition. Start supplementing correctly, which I know you guys also build these protocols at Next Health, and then from there jump onto the bandwagon of these really expensive treatments.
Yes, exactly. Yep.
Also, Darshan, being in the business of health and wellness, not only are you like a world-class surgeon, you have essentially a longevity business.
Yep.
You have all these clinics, you guys are scaling, you've gone global. What are some of the things that were some of the biggest pitfalls growing at this stage? Because you guys scaled pretty quickly, right? And going international as well. What have been some things that have been incredible, but what have been some things that have been like, damn it, I didn't see that coming and that was really hard?
So, I think it's what we've been talking about in this podcast today is this interaction between regulatory environments and also like modern therapeutics, right? And so because I'm come from a surgical background, I'm so used to regulatory environments, right? I used to operate surgery centers, which obviously, like if you're having surgery, if that is not done in a safe, clean environment, it's a huge problem. People can die, right? And so I come from this mindset of understanding like why regulatory exists.
It's so important.
Thank goodness it does, right? But also now you have these kind of newer therapeutics that are in regulatory struggles, right? Because the regulatory environment is not adapted quickly enough to allow some of this to actually work. And so now you develop what's called, when there's lack of regulation, you develop like a gray area, right? So there's all these gray areas with peptides and stem cells and these things that we're talking about. I find it very challenging because, even though I'm probably the best equipped person to deal with this, right? Like I come from a surgical background.
Yeah.
I've been a doctor for 30 years. I do find it very challenging.
You sit at the sweet spot between alternative functional health and having a traditional background, which a lot of people in the space don't have.
Right, exactly. And so it's great because it really forces us to up-level our game to the highest level because we need to be regulated and we have to do a lot of self-regulation. So for example, one of the things that we do is we have a pharmacist come into our locations on a quarterly basis and fill out an entire report giving a pharmaceutical review of what we're doing at our location and make sure we're doing it under the safest possible environments. Like those are the kind of things that we're doing to make sure we're functioning well regulatory wise.
And in terms of also like scaling from a business perspective, you guys put together a world-class medical board. You guys released that. And I thought that was so incredible to watch because a lot of clinics don't want to do that. They're like, I'm the doctor, I'm the star, but you have all these amazing, like I think Sarah Gottfried-Zoll was on your board, so many other incredible friends and colleagues. I think bringing in these additional specialists to be part of your Next Health family is something amazing to watch because you're saying, listen, we offer different types of services. We have different specialists across different verticals who can look at your health and kind of feed into it.
Yeah. To me, the advisory board is kind of, it's been very validating to what we're doing. So everyone on our advisory board, they've gotten to know me over the last 2 or 3 years through podcasting, through sharing the stage at different speaking engagements, and I've invited them into Next Health. And I've spent, sometimes like with some of them, I spend 3-4 hours with them at Next Health doing all the therapeutics, explaining the regulatory environment that we're working under, how we're self-regulating.
Patient research and data that's coming out.
Research data, all of it. And what's been awesome is every single one of them. And these are like the top doctors in the field. Like we have Dr. Hyman, Dr. Jeffrey Bland, Sarah Gottfried, you mentioned. The top scientists and doctors in the field are like, wait a minute, you guys are really doing this at the highest possible level. And I want to join your journey because I really believe
in how you're treating patients.
Not just how you're treating patients, but also how you're rethinking the entire healthcare industry. Because, we have this healthcare industry that's developed over the last 100 years, and thank God we have it. But it was developed with the mindset of treating emergencies and really bad things, right? Like when you have a heart attack and you need to go get a stent,
It's a
put
sick
in
care
immediately.
system,
It's
as
a
I
sick
call it.
care system, right? It's like it was built to take care of you in the last piece of your health journey when you really, really need help.
Versus keeping you actually healthy along the way, which is what a healthcare system should be doing.
Exactly. And so my whole thesis with Next Health was I'm going to stop trying to fix the current healthcare system because it's needed and is there for a reason.
Right.
Let's just develop something new, something fully focused.
That runs parallel next to it that will
Exactly.
keep you out of the system longer.
Right. And completely like focused on keeping you out of the system. But say you do need to go into the system because you have some kind of chronic disease. A lot of people have found themselves on multiple medications. We actually want to reverse the chronic disease. And so that's kind of what we're building at Next Health. And so our advisory board are like, they're there because they fully believe in the mission of what we're doing and to the level of what we're doing it as.
Also, you guys have really advanced things like the MRI machine that you basically put everyone through. And it's like really incredible to basically start someone's journey being like, we're going to get every single biomarker, every single data point we can on your health, and then build essentially a protocol around it. So not only is it preventative from day one, but can keep you out of the system as you age.
Exactly. Yeah, I think we have such incredible diagnostics out there. And so just to paint that full picture of what's going on with your body with diagnostics is so valuable to us. I mean, if you look at the human body, it is the most incredible machine ever created, right? And then you look at like an F1 car, okay? Look at the $100 million of diagnostic equipment that F1 racers use for races, right? And I'd argue the F1 race car is probably one thousandth or millionth of the complexity of the human body, right? So why don't we use like technology the way we use for F1 races to really fine tune our biology? And so I think as time moves forward, we've developed incredible diagnostic equipment and technology for the sick care system. Let's use it for this new healthcare system where we use it earlier when it's more valuable. I would even, argue to like reverse the destiny of your health.
You also talked about last night about some AI that you're very excited about in healthcare. Can we touch upon that?
Yes. So AI's finally gotten to the point where it really can help us connect the dots. And so we've built an entire patient healthcare dashboard that every patient will get access to by being a member of Next Health, where they can basically upload everything they've ever done for their health ever into this. And the AI will sort through all their records, all their MRI scans, CAT scans, blood tests, urine, everything you have, connect to every wearable and bring all of that data together in its brain to then create like a dashboard of your health that you can then talk to the AI about all of it. And it's all like supervised by our clinicians as well. So there's a clinician in the loop.
That's incredible. So somebody comes in, they supply all their information and looks at every single data point over the 5, 10, 15 years, however long they can trace it back. And then essentially they can speak to a specialist and be like, hey, what should be my protocol? How should I get started? And also find the missing gaps that maybe somebody might miss during an intake.
Exactly. And it's been transformative. I mean, we're just starting to use this in the last couple of months. Like it even helps the doctors fill in the gaps of what they didn't even notice.
Yeah.
They're like, oh, wait a minute.
We didn't see that correlating over there.
And you should see how incredible this is, like tying genetics into the blood markers. And like it's really the way healthcare should be working, because like if you have a genetic susceptibility to something, then your threshold to be put on a medication or a supplement protocol should rise, because now it's more important for you than for other people. Now we can really practice end of one personalized medicine.
That's amazing.
Yeah.
Darshan, I've really enjoyed speaking to you and
Thank
sitting
you.
down with you. And obviously, Vibrant, thank you so much for hosting us on the show today.
Vibrant is great.
Yeah,
man.
Vibrant's
Talk
great.
about data points. Like
Yeah.
we get so many data points with these tests. It's
I mean,
it's thank goodness we have it,
I always say to everybody, I think it's one of the top at-home diagnostic testing companies in the absolute world. It really offers tools and resources to people to get started.
It's so awesome.
Yeah.
It really is.
Thank you for making time this morning and coming on the show.
Thank you. It's so amazing to meet people like yourself as well, because I feel like we're kindred spirits, just really trying to help a lot of people
And get the word out there.
Get the word out there. And so thank you for having me.